Hello, everyone, and welcome to Vibration, where I empower individuals to speak their distinct truth, passions, and personal message on a global online stage. I'm your host, Michelle McDonald, passionate author, speaker, and entrepreneur. And tonight's episode is sponsored by Amber L, a Bahamian artisan skincare line that encourages you to nourish your everyday skin glow. Here in the Bahamas, there are certain aspects of the medical field that really stand out to us because of the way it affects us, our families, and loved ones. With medicine and guidance, we are able to make better decisions that allow us to continue our longevity in life and also increase our quality of life. In connection with this and the theme Representation Matters, Faces of the Caribbean, I present tonight's topic, When is Surgery Necessary? Understanding Cancer and Hepatobiliary Concerns, with my special guest, Dr. Dawn Major, who is a graduate of the University of West Indies, St. Augustine. He did his surgical residency at UWI Bahamas, where he became the first Bahamian to complete the UWI Bahamas Surgical Residency Program. Dr. Major also completed his surgical oncology and hepatobiliary fellowship at the Tom Baker Cancer Center in Calgary, Alberta, Canada. He is currently a consultant surgical oncologist and hepatobiliary surgeon at both Princess Margaret Hospital and Doctors Hospital here in Nassau, Bahamas. Dr. Major is married and is the proud father of three beautiful children. Dr. Major, welcome to the stage tonight.
Thank you, Michelle. Thank you for those kind words, and thank you for inviting me to the show tonight. And I'm pretty happy to be here, and pretty happy to tell my story and share some of the knowledge that I've accumulated over the years.
Excellent. I have had so many people who are interested in this topic. They were like, I'm tuning in, I want to know more. And so they're just as ready to go as you are. So I cannot wait to get into it.
Awesome.
So the very first thing is congratulations on that amazing accomplishment with you being the first Bahamian to complete that surgical residency. That was huge, and it really showed your representation to your homeland, and also a pretty good way to show your skills to everyone else as well. What was it that really inspired you to take on the medical field and choose these two areas?
Boy, that's a really good question. Inspiration, I would say, for me came at various stages in my life. So, from when I was younger to when I was in medical school to when I actually became a doctor, I was inspired by various different people that I'll try and touch on at some point tonight. But I would say, growing up, my very first interaction with inspiration, I would say, would be from my parents. My parents, Dawn and Dorothy Major, they were both hotel workers. That's where they actually met, in the hotel. I think they've been married for some 40 years now. And they were my first true inspiration with respect to, with hard work, dedication, you can do anything that you want, right? From as long as I can remember, my mom, she would always push me with respect to education. And my dad would always show me how to be a kind and loving man, basically, right? And knowing him, he would never complain. They never miss work, as tired as they may be, they would always be to work on time. And just watching this on a day-to-day basis made me realize that, this is what it is. You have to kind of put in the work to get the results in which you want. And she was the one that kind of pushed me to get into medicine because I tend to like the sciences, but wasn't 100% sure of what I wanted to do. My dad was more on the side of, accounting because I was also pretty good in math, but I still wanted to be able to interact with people and feel that I was actually helping people with respect to their day-to-day basis and their day-to-day lives. So I decided that, okay, let's stick with the sciences, and then we go into medicine. Went off to medical school in Jamaica. That was my first stop, right? And there, it was a bit of a rocky road. It was a bit change from, being at home with your parents, and now you're on your own in a foreign country like Jamaica. You know, a lot of reggae music, a lot of everything else, fun, glamour, all of the above. And I was involved with everything. But what ended up happening was Jamaica, I didn't think was a good fit for me. It was too much of, the fun life and not enough of the work life, right? So what ended up happening is after my second year, I transferred out of Jamaica to Trinidad. And in Trinidad, this is where I met I guess, another person that inspired me. And he was actually a fellow or colleague of mine in the medical school. His name was John Bear. He's also a physician now. And he was an older guy. He might have been probably about 6 or 7 years older than I was. And then just watching his dedication and his drive in medical school, I was like, hold on now. This guy here, every night you see him studying. Every night. I was like, no, I can't have this guy beating me, So it kind of became like a little competition between him and myself, and we would kind of push each other to do good and to get good grades, et cetera, et cetera. And in the end, we were both able to graduate on time from medical school. He decided that he wanted to do internal medicine, but me, I wanted to do surgery. And one of the reasons why I chose surgery was that during my rotations at the Princess Margaret Hospital here in the Bahamas, I rotated on surgery, pediatrics, medicine, psychiatry, as well as obs and gynae. And one of the recurring themes that I noticed was that, a lot of patients are ill because they don't necessarily take their medications, right?
Yeah.
So in medicine, for instance, you have somebody who's hypertensive or has heart failure. We say, okay, we've got this under control in hospital. Okay, here's a list of medications we want you to take. 3 weeks later, the patient's right back in the hospital with the same problem that they came out with. And it's like, what happened? Were you not taking your medications? Oh, well, doc, this one didn't make me feel this way. I keep forgetting to take this one and that one. And it's like, I couldn't see myself going through that, routine every day or every other day with patients, trying to get them to take their medications. Obs and gynae, basically, delivering babies after seeing one delivery, that was enough for me to know that, hey, I don't want to see that ever again. I've watched my children be delivered. I think one of them, the other two, not. No, that was it. Just to see that head coming out. Yeah. And then surgery now. Surgery, to me, kind of fixed problems. Okay. So if you have a problem, let's say you have a ruptured appendix, you go in, they resuscitate you, give you some antibiotics, you take it to the operating room, you take out your appendix, and in a few days you're good to go home, and you'll never have that problem again because it's fixed. So I like that idea of being able to, truly help and fix things and not necessarily have to rely so much on the patient and their compliance with respect to taking medications. All right, so that is one of the things that kind of drove me towards surgery. And now when I got into surgery, how I got into this oncology portion of it, the residency at Bahamas was a 5-year program, right? Just like most general surgery residencies across the globe, usually 5 years. And they had a few residents that went before me, but they weren't necessarily getting through. Like, you have 2 major exams that you take, one after the 2nd year and then one after the 5th year. And they were getting held up at the 2nd year exam. And some of the guys there, namely Dr. Shrikant, he's a surgeon, he's a plastic surgeon here in the Bahamas. And he's a really good guy. he kind of saw my interest in surgery, and he truly mentored and pushed me to say, okay, this is what you really need to do to get through these exams. And I always remember, even though he kind of inspired me to do the program here, because a lot of people would just take their U.S. exams and go abroad and
Yeah.
do their residency in the U.S. or in the U.K. He encouraged me to stay at home because the surgeons at home are great. We have a lot of experience. We see a lot of disease here in the Bahamas,
Yes.
and they were really trying to boost up the program. So I said, sure, I'll stay. I'll give it a shot. Still pretty young at the time, probably like 27 or so. And, didn't have any kids, no family. So why not? Let's do it, right? And I always remember, like, probably a month or so before the second year exams, he saw me at a function. I was at a party, and he was there as well. And he's like, boy, Dawn, I don't see you studying, I said, yeah, I can be all right. He said, how much you want to bet you want to pass none of these exams? I was like,
What?
wow, are you serious? So just to show him up, I had to pass them all, and I sure did. I passed them. I was able to move on to the third year. And this is where now I started to work with Dr. Francis. He's also another surgical oncologist and hepatobiliary surgeon.
Yeah.
And he put the question to me, what do I want to do all day? Do I want to do complex procedures? So liver cases, pancreas cases, bile duct, gallbladder cases. Or do I just want to do like lumps and bumps all day and little hernias here and there all day? And to me, doing lumps and bumps, doing hernias is fine. They're low risk on pretty good reward cases, but there's really not much thought to go into it. So it almost becomes like you're a machine, just pumping stuff out. But when you get the complex cases, you have to actually sit down and think and make sure you're doing the right thing and making the right decisions for these patients. So I said, you know what? I like the idea of being a complex surgeon. And he truly inspired me to say, go ahead and get through my exams. And then once I got through my exams, I was able to get a position in Canada where I trained for another 2 years in doing, surgical oncology and hepatobiliary surgery. And I returned home in 2019, and I've been working at Princess Margaret Doctors Hospital as well as Center Medical Center ever since. So those are some of my inspirations along the way.
That is so cool. And I must applaud you for staying because the person who inspired you, that doctor, he was so right. There are a lot of persons, they get hyped up, especially, in their 20s, in college. They're just like, I just want to continue to explore the world. I just want to like be out there. And, there's nothing wrong with that. But giving back to like where you come from, especially when you know that there are cases here, there are diseases here, there are persons being impacted, and the less help that they have medically, then it really doesn't give them much options. And so you choosing to listen to him and come back here and continue to pave the way, that really says a lot about the kindness and thinking of others that your parents instilled in you, which is really awesome. So, of course, kudos to them for that. And, thank you for choosing to still be here.
Yes. This is home, because I feel like these are my people and I really want to help them as best as I can.
Right? Yeah.
Because if everybody goes away, then what do we have left?
Exactly. And we just kind of look back and, wonder, what could I have done, when there's a lot that each of us can do as long as we stay here and continue to give back in some way.
Yeah, I agree. Because it is, to go to the U.S., you'll have to sit an exam. But once you sit the exam, then you go. And a lot of people, when they go, they tend not to come back. So that was one of my worries too. Let's say if I were to go sit the exam, would I truly come back? You experience the U.S. life and everything being so organized. And to say come back to the Bahamas where, you have all these issues, you got to stand on long lines for simple things that in the US you plug in a computer and it's delivered to your doorstep. So, but we got to make it better. We got to want better for ourselves. So this is why I'm here.
Absolutely. And the good thing is, once you're able to see what needs to be worked on with you being here and others kind of seeing the same thing, there's room for change. And it just provides a lot of hope for others. We may not have it now, but we will have it eventually. And so that's amazing. And the good thing is we just got a heart from one of our listeners, so they are really loving everything that you have to say and supporting.
Awesome. Awesome.
Yeah, that's really good. So here in the Bahamas and the Caribbean, you kind of touched on it with oncology and understanding that there are certain diseases that are here. Cancer is one of the more prominent ones that Bahamians are familiar with, and it's quite common. Are you able to say what are the contributing factors to the numbers being so high?
Well, generally with respect to cancer, right, there are some risk factors, right? Or if I were to start out to say, most times we don't know what causes the cancer, right? If I were to be honest, because you could be the healthiest person, you whichever diet, vegan or vegetarian or fruit diet or whatever, you exercise every day, you're not overweight, you don't smoke, you don't drink, and at 40 or 45, you could develop a cancer, and you didn't do anything wrong. You did, as far as you did everything within your power. You did everything to live right and to be healthy, but it can still happen, right? So when we talk about cancer development, you look at risk factors, right? So things that can increase your chances of developing it. Not necessarily saying that this is going to cause it, but it can increase your chance of getting it, right? And we divide our risk factors into modifiable and non-modifiable. So basically, modifiable is something that you can actually do something about. Non-modifiable, that's just luck of the draw. So something that's non-modifiable is age. You can't do anything about your age. Every day you're going to get older, right? That's just how life is. Another non-modifiable thing would be, the family that you're born into. You have no choice over that. You may have a strong family history of various cancers, such as breast and colorectal, and that's just the way it is for you. You couldn't do anything about it. And those are the two major non-modifiable things that we talk about: age and family history. Now, stuff we can do things about now, or modifiable risk factors, would be our habits.
Mm-hmm.
Some people have some bad habits, things such as smoking, cigarette smoking, right? That's something that you can modify. Because if you're a smoker, you increase your chances almost tenfold in developing something like lung cancer or stomach cancer, right? If you are constantly abusing alcohol, you increase your chances of developing esophageal cancer or stomach cancer again, or even pancreas cancer, right? If you're overweight or obese, you increase your chances of developing breast cancer in women, right? In men, colorectal cancer, or in women, colorectal cancer. So these three things that we can actually do something about: our weight, our habits, and then also your diet. Also depend on what you eat. So if you eat diets, that are, high in fats, this can increase your chance of developing various cancers. Or diets that are high in processed foods also can
Mm-hmm.
increase the chance of developing certain types of cancers. Now, again, as I stated before, you could have terrible diet, eat processed food all day. You could smoke all the days of your life. You could drink all the days of your life, and you could live to see 90 and nothing ever happens. But that's not the common thing that happens. The majority of people that have these habits, they tend to develop cancers related to the habits that they have, right? So if you want to minimize that, you got to cut those things out. right? And the other thing too is sun exposure, UV light,
Hmm.
because that can increase your chance of developing some skin cancers. So it's important that we wear our sunblock to minimize that risk. I know a lot of people think because we have all this melanin, we don't need
Oh
sunscreen,
yeah.
but we still should be using sunscreen, right? Because it does you can get things such as melanomas and skin cancers. May not be as common as our Caucasian counterparts, but there is a risk of developing it, right? So you want to, affect the things that you can actually control.
Mm-hmm.
And things such as stress. Some
Yeah.
people
Big one.
say some people are stressed out all the days of their life, and that can shorten your
Mhm.
life. That increase your chance of developing cancer as well. Right. So you try and minimize these things. It's easier said than done. Because sometimes these things people have been doing for 5, 10, 15 years and they've already, conformed to it. But you have to kind of want better for yourself and want better for your family and stuff like that. So you have to think about it and try your best to make that change. You know? Yeah.
Definitely, I agree. And I really appreciate the variety of habits that you've mentioned because a lot of us don't think about it. So I think on a regular basis, we would be familiar with high in fat, high in processed foods, and also thinking about smoking or drinking. But hearing sun exposure may be something that's like, oh, wow, really? Because, we
Yeah, I
in
know.
some tropical Bahamas, sun everywhere. Like
Yeah, yeah,
we be
yeah.
thinking, this our gift. We supposed to be outside. you know, what is sunscreen? I don't have to worry about that because, as you stated, it's not as common. And so
No, it's not.
when we hear it, it's like, are you serious? Like, but this is everywhere. This
Yep.
is where I'm from. But
Yep.
as you stated, you have to want better and you have to choose better. And stress, oh, such a huge one that a lot of people struggle with, and we tend
Mm-hmm.
to not understand the mind, body, and soul connection. In that, it kind of filters through, and it can stay in there in a
Yeah,
sense.
yeah, it can. You know, and I mean, the thing about it too is that you kind of have to identify the stresses. Like, what is it that causes you the most stress? So you have to actually
Yes.
physically sit down and try and figure out what is it that I'm stressing about, and try and figure out the best way to remove that stress from your life. So if it's a job that you're stressed over, then you might have to pick up a side hustle and try and get that to a point where you can leave that job, or if it's, family and stuff like that, you got to sit down and you talk to them and try your best to work it out. But you can't just let it sit there because all it can do is grow. And these disease processes or these, smoking, drinking, stress, the bad foods, not only do they, increase your chance of developing cancer, they also increase your chance of developing regular non-communicable diseases, things such as hypertension, diabetes, and chronic kidney disease. So those are like being risk factors for almost anything that's bad, right? So if you want to potentially shorten your life, you just lead a lifestyle like that, which is never good.
Definitely. So the thing is, in understanding the things that we can control versus those that we can't, and also kind of taking that with grace, because sometimes when people hear that they can't change something, they kind of automatically feel defeated. And so I
Mm-hmm.
love the way that you were able to kind of bring that across to us. Is just to say that this can increase your risk, but it's not saying that it will happen. So it
No,
kind of
no.
removes that sense of like anxiety and fear that people can kind of get when a certain age comes around, or they start getting their family history and they get a little worried. And it's just to kind of understand, let's focus on what we can change. Let's focus
Yes.
on what's in my power. What can I start today? Let me choose to be very present and not just get overly concerned
Yep.
about a future
Yep.
that doesn't even exist. And I'm sure that you meet, patients like that all the time. They're just like, Dr. Mayer, I don't know, you know?
Yeah, like they all the way down the road, but we're here. We're here. Let's deal with the here and now, not 10 years from now, you know. Let's make good choices now that can affect you 10 years from now.
Yeah. And so, of course, the big question is now, we understand what can contribute to it. I'm familiar with my history. I know what to do next. And I'm really getting into what I can change. However, I may be starting to experience symptoms or maybe just warning signs, signals that my body is giving me. How do I know when it's time for surgery?
Okay. Well, first of all, a good question. Now, when it comes to surgery and cancer, it's always related to the stage of the cancer, right?
Mm.
So, first of all, you need to have, a diagnosis. And generally, how we get a diagnosis for a patient of cancer, we tend to take a history. So we sit down. We can sit down in a forum like this or even face to face, and we talk to them about the symptoms that they may be experiencing. We find out about their family history. We find out about their social history. So do they drink? Do they smoke? We find out if they need past medical history or if they've had any surgeries before. And then once we sit down and we've talked to them and find out all this information, the next step is that we examine them. So wherever the area of complaint is, we examine that area and we try and find if we could find anything or if we could feel anything or any associated swellings or anything anywhere else. And then once that's done, then the next step is investigation. So investigations tend to be blood investigations or imaging investigations. We tend to just do baseline, blood counts and electrolytes in the blood. And then depending which area you're concerned about, so if it's a woman and, she's concerned about her breast, you may get a mammogram or an ultrasound. Or if you're concerned about your colon or something like that, you may have some constipation or you may have some blood in your stool. You'll likely end up getting a CT scan of the abdomen and a colonoscopy. And once we see the area of concern, we have to do a biopsy to confirm that this is what it is. And a biopsy is just taking a piece of it, not necessarily taking the whole thing out, taking a piece of it, sending it to the lab, and the lab telling us, okay, yes, this is a cancer, right? Now, once you've got that diagnosis, this is where all the testing now ramps up. So generally, we do a scan of your whole body just to make sure that this thing hasn't gone anywhere else. And once it's localized to the organ of concern now, this is where they kind of refer to the surgeon, and the surgeon now has to figure out what's the best operation for this procedure or for this cancer. So if we were to take, let's say, a breast cancer, for instance, right? Young lady comes, she's diagnosed with breast cancer. First thing we do, we stage her, and there generally are 4 stages for cancer, right? So stage 1 is when it's early, right? So it hasn't spread anywhere. Stage 2 still hasn't spread anywhere, but the tumor is just a bit bigger. Stage 3 is when it spread to the lymph nodes, and stage 4 is when it spread throughout the body. So obviously, as the stage goes up, the cancer itself has a worse prognosis or is a more advanced cancer, right? So generally, we want to catch these cancers at stage 1, probably stage 2, and these patients tend to do the best. So surgery is generally reserved for stage 1, 2, and 3, right? The only time you'll operate on somebody with a stage 4 cancer is if they have some complication related to the cancer. So let's say the cancer is bleeding profusely and you can't stop it, right? Or if it's a cancer of the colon and it's causing a blockage of the colon and the patient can't eat, they're persistently vomiting, then you have to go in and relieve that blockage, right? Or if it's the colon or the stomach and that cancer ruptures on the inside, you got to go in and take that out and clean that up. But knowing that in stage 4, you're not necessarily trying to cure this patient. You're just trying to relieve their symptoms and ensure that they have a better quality of life, right? But stage 1 and 2, we tend to try and go for cure. So if you have an early stage breast cancer, we'll go ahead and we'll cut that out, or depending on what the patient wants. Sometimes they want the whole breast off. We remove the breast. And then depending on the pathology, because we send it all to the lab and they look at it and they tell us the aggressive nature of it. If it's pretty aggressive, then those individuals, they would tend to go on to get adjuvant chemotherapy or chemotherapy after surgery. Sometimes it's a big bulky tumor, lymph node involvement, and you can't necessarily operate right away. Those patients could get chemotherapy first. And what we do is with the chemotherapy first, that tends to shrink it down. So now we can go in and operate and take it out and get rid of it, send it to the lab, and then go from there, right? So again, surgery is generally reserved for those patients with early stage cancer, or in the later stages, if they have some complication related to the cancer, then we'll offer them surgery. Because really and truly, as far as cancer goes, surgery is the only thing that's kind of proven to say, get rid of it, right? Because chemotherapy, yes, it may shrink it, but it doesn't necessarily get rid of it altogether. Radiation kind of does the same thing, it just kind of shrinks it, but it's still there. The only way to truly get rid of it is to cut it out. Now, saying that, all cancers have a risk of returning, cut it out or not, so you really want to get them early, because the ones that are got early, the chances of them coming back are less, right? Because then you know for sure they haven't spread anywhere else. Because sometimes you could have little cancer cells like floating around in the blood that you can't see, that are not being picked up on imaging. And then once you've done everything, some 5, 6 years later, they come to find out they have a cancer somewhere else, and that's the previous cancer had already spread. So the important thing about it is, like I said, can't stress it enough, is catching it early. And how we catch it early is a few ways, one of which is known as screening.
Yes.
So screening is when we take somebody that has totally no symptoms of the cancer and we do a test on them that is pretty sensitive towards identifying that cancer. And we have a means of treating that cancer if we were to pick it up on that test. So common screening tests that we do would be the mammogram for women. So generally women, once they reach the age of 40, this is for average risk, so they don't have a strong family history. So they don't have, sisters and aunts and parent and mom with breast cancer. It's just, no one in the family, they're pretty straightforward. At the age of 40, they should get a mammogram. Some people do it every year, some people do it every other year. It's up to the patient and their preference. And then another screening tool, let's say you're looking at colorectal. So let's looking for colon cancer. The colonoscopy is a gold standard screening tool there. And that is recommended for all individuals at the age of 45 that they get a colonoscopy. And colonoscopy now is a bit more invasive than the mammogram for breasts for women. The colonoscopy, you actually have to go to an operating suite. They have to give you a little medication, make you drowsy, and then we pass the camera up the back passage, have a look, take a bunch of pictures. If we see anything, we'll biopsy it. And usually you go home the same day. So when you wake up, feel okay, you go home, sleep it off, and then back to work the following day. Now, some people get a bit afraid of the colonoscopy because they gotta go to, get this little medication, make them drowsy, and then the men, oh, we don't want nothing up our hip.
Mm-hmm.
But the thing about it is, you're not gonna feel it because you're gonna be asleep, right? And it could be life-saving, because up to 25% of colon cancers, especially on the right side, when patients finally do get symptoms, they already got stage 4 cancer.
Wow.
And that's 1 in 4 people who have right-sided colon cancers. So had they gotten a colonoscopy some 3-4 years prior, they might have gotten it early enough to just deal with it at the colonoscopy, and they would have never gotten it. So we can't stress that enough. Get your colonoscopies at 45, mammograms at 40, and again for men, get your prostate checked at the age of 40 as well. And generally, that's more of a blood test now. It's very rare that they do the finger exam, because I know a lot of men, they're not interested in that either. So, so they do a blood test. If the blood test shows anything, then you may need an exam, but commonly it's a blood test. All right.
I appreciate that, the way that you're able to really break all of that down, because for a lot of people, just the idea of surgery is so scary. And so understanding that there are steps that lead up to that, your doctor is with you every step of the way. You can ask questions and they want you involved. They'll let what are the results, how are you feeling? Let's talk about it. These are the next steps. Well, what do you think about that type of thing? Instead of kind of feeling as though um, this is almost like, I don't necessarily want to say the end, but it's just that people panic,
Yeah.
they get
Yeah.
stressed. And as you mentioned as well, males are not as keen on being healthy and fit outside of the gym. Women are
No.
like, they schedule everything. I got to see my doctor. This is my one and only doctor. I have a backup doctor.
Mm-hmm.
I do this
Mm-hmm.
annually, semi-annually. I'm committed. This is like, it's a thing. For males, it's kind of like, I'm going to have to drag you to do this.
Yes, and that is how a lot of males get to the doctor's office. They come with their wives, and the wives are sitting right there, and I'm sure that they did not want to come here. And she just kind of forced them to say, "Come, let's go and get this checked out." And a lot of times we have to have symptoms. Something has to be bothering us, and it has to be bothering us for a while before we say, "You know what? Let me go get this checked out." And I'm here to tell you now that that's not a good thing, right? Because you don't want to have something bothering you for months on end, and then when you come to see the doctor, finally you mustered up the courage to go and see the doctor, and they're like, "Well, it's stage 3 or stage 4 if it is something." Because at that time there's really no surgical option, and most of it is just chemotherapy, and then you'd be like, wow, I knew this was what it was, but had you come to see the doctor 6 months ago or a year ago when you're experiencing symptoms, it wouldn't have been this far.
Yeah.
So it's something that we got to stress for our men, that hey, get yourself checked out. And I always tell people that, like how you say, women, you have your appointments, you have it all set up. I always tell the guys that find yourself a doctor that you could relate to. You don't have to be a male; it could be a female. Someone that you're comfortable talking to, and there are a lot of them out there, right? And you go and you visit them once every month, or once every 6 months, or once a year, just to do routine physicals, right? And then that way you can develop a relationship with them, and then you can pick up stuff early, and they could tell you things about your life and lifestyle that you could potentially change or look into, as opposed to just sitting at home saying, well, I'm okay, I'll be fine, because we don't know what's going on in the inside
It's
until
true.
it's kind of late.
Yeah. Definitely. And I like to understanding and emphasizing that the doctor patient relationship doesn't have to be so static.
No.
We often feel like, when we go, it's always something serious. And when they talk to us, it's just going to be very serious. And it's just, if I go to see my doctor, this is a negative thing. But in understanding, as you said, let's build like a real relationship, because that's where the trust come in.
Yeah.
If I trust you, I'm going to listen to you. I'm going to ask questions. I'm going to, take the medication. I'm going to follow the habits that you say that I should, because I feel as though you know me. But more importantly, I feel as though I know you. And so it's just this beautiful exchange of information.
It is. It is. And it's a great thing when you can get that relationship like that. And most commonly that happens with like the general practitioners or the family docs, because they're like the first line. So they see you, for routine physicals, or if you have any problems, you tend to go and see them first. Usually by the time you get to see me, you have a problem. So you're coming to see me, and we're gonna sit down and discuss how best to fix this problem. Right. And most commonly there are different ways in which you can do it. So the patient as well as the physician is involved in the decision making. Back in the day, early in medicine, it was just, okay, you have this, so you need to do this, and let's do that. There's really no input from the patient, right? But nowadays, we have the patient, we make sure that they understand what's going on, and then they get to make decisions on what happens to them. Did we freeze?
Hi, everyone. Thank you for still tuning in. We just had a little bit of a power break, so I appreciate you all still being here with us tonight. So, yes, Dr. Major, as you were saying, that when the patients do come to you, they do recognize that they have a problem, and you work very closely with them to find the best solution.
We do. Yes, yes. And again, some patients, they kind of appreciate that you give them the options and you tell them, and you let them think about what it is that we want to do to their body, because basically they're giving us permission to do stuff to their body, so make cuts, take pieces out, put pieces in, et cetera, et cetera. So they have to fully understand what's going on, and what could and could not happen before they kind of give us permission to say, okay, yes, doc, I am on board. Let's get this done.
Yeah, and I think that that really allows not only them, but their families and loved ones to breathe a sigh of relief, and just kind of understanding that you're not just kind of going into it, trying to figure out, like, what are the risks, what's going to happen. I So the next thing for us is understanding the term hepatobiliary. This is a complicated word for persons that haven't heard it before, and I'm sure that there are many audience members who are not familiar. So can you break that down a little bit for us? Help us to kind of understand, what is it, what parts of the body it involves, and what diseases should we be aware of?
Okay, great question. So technically, the full term is hepatopancreaticobiliary, so HPB. So I just kind of leave out the P part to kind of shorten it, right? So just hepatobiliary, right? And that's a subspecialty in surgery, in general surgery, that focuses on the liver, the pancreas, the gallbladder, and the bile duct, right? So that is the area in which we are trained to operate. And the reason why they have HPB surgeons is because general surgeons, they don't get that much exposure in that area, in those organs, right? So general surgeons, we do a lot of, colon, stomach, small intestine work. Some may do esophagus, some, and then things on the outside, so skin, breasts, lumps and bumps, hernias. But when it comes to operating on the liver, the pancreas, the bile duct, it's not a common procedure for the general surgeon. And not a lot of hepatobiliary surgeons are out there. When we look, basically, maybe some in America is probably like some 200, maybe 300 hepatobiliary surgeons. And it's a very unique specialty, and that it allows you to operate on these areas that most surgeons aren't comfortable operating on. And the reason why they're uncomfortable operating on it is because these are very high risk areas to operate on. So the chances of some morbidity or something going wrong in these areas tend to be high, and then the chances of somebody actually dying from an operation in that area also tends to be relatively high compared to other areas. But the thing about it is, there's no good treatment outside of operating on it. So that is why you kind of have to take those risks, because chemotherapy doesn't necessarily work for HPV tumors. Radiation, not so much. So the only thing truly is surgery, right? And you have to have training in that area in order to say go ahead and operate, because there are some vital structures that are around there that if you get into, within 2 minutes you could lose the patient's whole blood volume, and it's scary. It's like they call it audible bleeding. You could hear the bleeding, and that's just blood just pouring out, right? So you don't want to be in that area messing around and not 100% sure what you're doing. So a training in hepatobiliary basically is about a year. So when I went to Canada, I did 2 years. One was in surgical oncology, basically, which is just cancer surgery. And then the other year was hepatobiliary. And all I did all day, like 5 days out of the week, was operate on livers, operate on pancreas, and operate on bile ducts, right? And the common tumors that affect the liver that we operate on most commonly is spread. So like a secondary tumor. So it's come from some other organ and spread to the liver. And we tend to take those out when it's just maybe a few spots that you can clear and the rest of the liver is okay. Sometimes you can get a primary liver cancer, which is known as hepatocellular carcinoma, or HCC. Not that common here in the Bahamas, but I've seen it a lot in Canada where I train. And again, you just go ahead and you cut that out to an area of normal liver. And the thing about the liver is you can take out of a healthy liver, you can take out up to 80% of somebody's healthy liver and leave them at 20%, and they could still function normally afterwards, right? So the liver is a pretty beautiful
Wow.
organ. Yeah, you can take out almost all of it, right? But once, long as enough, you leave two segments that are contiguous, and it's about 20%. But the liver has to be normal. But if you have like somebody who has cirrhosis, then you got to take out less, probably like 30 or 40%. Or if you have somebody that like chemotherapy before, you probably could only take out about 50 to 60% safely, right? But then there's other tumors that affect like the pancreas. So there's pancreatic cancer, which is a pretty deadly cancer, right? And but the good thing about it is it affects you later on in life. So when you're like 6 and 7 decades, so most commonly like in your 60s or 70s, you'll get it. So you tend to live hopefully a good life up until then, right? And the thing about it is there's no real screening for pancreatic cancer. So generally people, if they have pancreatic cancer, if it's in the head of the pancreas, one of their first symptoms would be jaundice. So they'll notice the eyes turn yellow. And if you ever were to see that, go immediately to your doctor or to the emergency room, because that is one of the signs of pancreatic cancer, right? Some people just get weight loss and they can't explain it. So they're eating normally, they're not changing anything, but they're dropping weight. That's also a sign of something's going on within the body, sign of pancreatic cancer, as well as other cancers. So you'd want to go ahead and get that checked out. Right? And then finally, things are the bile duct. The bile duct cancers aren't that common, but they can happen. And generally, they also too present with jaundice, because the bile duct is the tubular structure that drains the liver of its bile. And anytime that's blocked, everything builds back up into the liver, spills over into the blood. The eyes will become yellow. Your urine will look like Coke soda, and your stool will look very pale. So if ever you were to see anything like that, yeah, time to go to see the doctor. All right. So hepatobiliary in a nutshell basically just focuses on those three main organs that, you know, is pretty high risk, and general surgeons tend not to bother with it.
And so, would you say then that these concerns or these symptoms that you mentioned would definitely lead that person to needing surgery?
So again, it all depends on, how the stage of it. Remember, one, two, three, four. And then it also depends on which part or which organ it involves and its relationship to those important blood vessels as well as important other structures. So you'll have to kind of sit down and study the scans and determine whether or not this is something that we can cut out and we can cut it out safely versus it's something that we probably can't cut out and we may need to send them for chemotherapy and hopefully they'll shrink down and then you review after. Now the good thing about I guess these cancers is that they're pretty rare. These HPV cancers, they kind of make up less than 1% of all the cancers. But when you do get them, they tend to be pretty hard to treat. So that's why if you can get it early enough, you can potentially cut it out and then send those patients for chemo or radiation after. All right. So I guess, like I said, that's one good thing. They're not that common, like the breast and the colorectal cancer and the prostate, but they are something that you got to be aware of.
Definitely. And I appreciate you being able to break that down for us because sometimes these are the things that do exist in our family history and we don't understand it because people don't talk about it. There aren't usually a lot of information. And then, as you stated, it's so rare, especially here in the Bahamas. And so you just feel this kind of disconnect. You want to know more, but you don't even know where to start. So
Yeah.
you being able to just kind of identify the different organs, the signs we should be looking for, remembering to take it one step at a time, goes to the doctor, goes through the process of investigation, diagnosis, examination, all of that. Before we kind of do our self-diagnosing. I'm sure you're familiar. You hear a lot of
Yep.
that.
Yep.
I saw this in Google,
Yep.
WebMD. My mama said,
Yeah, Google it. Google is the ultimate doctor. I
yeah,
know. But I
but
just kind of tell them, okay, this is what Google says, but this is what it is, and this is what we we should be thinking about doing.
exactly. Yes. Remembering to just like be present and try to be aware that there may seem to be a lot of different answers, but taking it from someone that has the expertise, that has the knowledge and the experience is more of the safer bet, and someone you
Yeah.
can ask questions to so that you understand what's going on rather than just kind of, typing it away is the better route to go.
Because couple of things I like to tell patients is before you come, make sure you have your questions ready
Mm-hmm.
to write it down. I think writing it down is the best. So you come with your list or come written down on your phone, and then you ask questions. That's not a problem. And then especially for like cancer patients, I kind of like if they bring a relative. You know, especially the first visit. You bring a relative with you because once you already say that cancer word, the rest of the conversation they don't even hear because
Yeah.
it's like you drop that bomb on them and boom, they can't hear anything else after that. So it's always good when you go to see a doctor if you're worried about that or worried about getting bad news, then you should take a sister, a brother, a wife, husband, somebody that could be there for you and potentially support you through this hard diagnosis.
Absolutely. And I think that kind of brings this reminder that there's such a humanistic aspect to all of this. Medicine alone is complex, especially when you don't understand it. And we often feel that as patients, we're so much more on the vulnerable end of it all, right? We feel as though we've gotten the short end of the stick and we don't know how to necessarily travel this journey. So I really appreciate that you tell your patients to bring someone who cares about you, who's going to support you and come with your questions. It shows that you want to help them, you truly want to guide them through this and help them to understand what's going on with their body so that even after the surgery they can still choose to live their life and continue to be better than where they were before.
Because most of the times cancer isn't a death sentence, you know. Because we've come so far, we've had surgery, we've got a lot of chemotherapy medications, we've got radiation, all these things we can put together to treat that cancer and kind of make that something that's long term. So basically, it's almost like treating hypertension. Not necessarily that, okay, you get cancer and then, in 10 days I'm going to be dead. No. We have options, all right? Especially if we get it early enough.
Yeah, and that's a PSA for males and females.
Yes.
Get it early enough. You screen, you trust your gut, because we sit there and we know that there's something, and it's the fear. It's the fear that we
It
let
is.
mislead us. And as
Mm-hmm.
you stated, we come back and we're just like, I know I should have come earlier.
Yeah. Because I've had many women that, they felt a lump, but because they're afraid, they hide it. They hide it from their family, friends. And then, a year and a half later, their breast is pretty much overrun by tumor, and you can't hide it anymore. So you have to come in because it starts to smell, it starts to bleed, and they'll tell you, yeah, doc, I noticed a lump about a year ago, but I was too afraid to come and get it checked out. And now a year later, it's not much can be done for that. And yeah, that's a pretty bad way to die for some people. You know. So if
And
you feel something that's abnormal, please get it checked out.
yeah, I think that was definitely something that needed to be shared, because there is certainly someone out there who is just thinking like, I don't know how to do this. I don't know if I can do this. I don't think that I have the courage, but it's an understanding that it's better now than later,
Yeah,
and your future self will thank you for making
definitely,
that decision
definitely,
for today.
totally agree.
So we've touched on this already, and we understand that you truly do care about your patients. But I can imagine being at both medical institutions, PMH and Doctors Hospital, can be quite a handful. What is it like trying to balance all of these patients and personalities and being able to focus on your work as a surgeon?
I mean, in the beginning, it was kind of hectic, to be honest. But now I've kind of developed, I guess, a routine. So I know where I'm supposed to be on a Monday or a Wednesday or a Friday. And I know, I'm giving my time to public patients on this day and private patients on this day. So I've now kind of been able to, like I say, develop a routine and then know when I can give time to my family. And basically, I try to be home as early as I can in the evenings to kind of make sure I spend time with my family, my wife, and kids. Because generally, in the surgical field, they're the ones that tend to get the short end of the stick. Because we could be out all hours of the night tending to patients, patient after patient, and then kind of, you know, the patients getting the care that they need, but on the back end, your family's kind of getting neglected because you are out here helping patients. So it's trying to find that balance that can be a challenge at times, but you have to work on it. And the thing about it too is that you want to work to generally both hospitals as well as privately because you don't necessarily want to negate the public patients, right? Because those are the ones that truly need your help,
Yes.
right? So you want to give your time to them, and then you also want to see your private patients as well because those are the ones that keep the light on, right? So you can't necessarily negate them either. So trying to find that balance in the beginning was a bit of a challenge, but I think I've been doing pretty okay with it, and I'm pretty happy with my work, home life balance so far.
Awesome. That's pretty good. So you have certainly shared a lot with us today. We can walk away understanding that there is so much within our power to change the course that we're on now when it comes to our medical health. Understanding the different organs that are involved in the specialized areas that you're in, and one of the most common aspects, which is cancer, knowing when to seek a doctor's help understanding what we can control, realizing that it is something that we can walk through together, and not to allow fear to stand in the way, which is a huge, huge factor that people need to be reassured us of. Let us know what is next for you, and of course, how can we seek a consultation and connect with you?
So what's next for me is now trying to give back, I guess, surgically,
Nice.
not necessarily to patients, but to other doctors.
Mm.
Trying to get them trained up in this area and making sure that, when I move on, that there's somebody, behind me to kind of carry this on.
Yeah.
So my next thing is I'm looking at a course in leadership. So trying to improve my leadership skills and actually get people to wanna do stuff like this. And I'm hoping to start the course. There's a course that's being offered, and it starts next year February. So I'm hoping to start next year February. It's just a 1 year course, and it's in Boston, I think. So that'll be my next thing. And then with respect to where you can find me for consultation, I am at both Centerville Medical Center. That's Cancer Surgery Bahamas.
Mm-hmm.
I'm there on Tuesday mornings and some Friday afternoons. And then I'm at Oak Tree Medical on Tuesday afternoons. You can call for CSB or Cancer Surgery Bahamas 3560226. And you can speak to one of the lovely nurses there, and they'll be able to kind of set you up, right? Or if you do have any questions for me, you can always feel free to email me. My email is don.major@gmail.com, and I'll be happy to answer any of your questions.
Excellent. Thank you so much for that. And that is so admirable. You just wanting to pay it forward and have more Bahamians involved, leaving that legacy, and also kind of igniting that passion to stay here, add to the Bahamas. Let's help our healthcare system to be better. Let's help our own people. So I'm sure that you will do well. I wish you all the best with that. Uh,
Thank you.
it's going to have such a great turnout, and you'll definitely make those who had inspired you very, very proud of the progress that you continue to make.
Thank you.
Dr. Major, you have been an amazing guest tonight. I appreciate that. You just mentioning all of the ways that you add to the community, the way that you see your patients, how encouraging you have been, and also so patient, being able to kind of say things in a way that we can understand, those of us who don't really understand medicine, but helping us to really connect with what can happen in our bodies and understanding that we don't have to be fearful. I see we actually have a comment, so someone really wanted to say something before we ended. And so we have Wealthy Petty. Thanks so much for sharing such an informative educational program with us. It gives us a sense of care for the wellness for people who depend on your expertise to help us on this journey. That really says a lot.
It does. Thank you. Thank you, Patty.
Thank you so much for sharing that comment. And, it just really shows that one conversation makes a difference. Sometimes we feel like no one is watching or no one is listening, but it can really make an impact. And even just this conversation today can encourage a lot of people to take that consultation, step into the office, and really think about what they may be experiencing now and how they want to change that for the future.
Well, yeah, that was my hope with this whole thing, that if you could get one patient to go in early and get checked out, not necessarily even having to come and see me, but just see a physician in general, I feel like I've done my job.
Definitely. And you've certainly been able to do it here tonight. I thank our audience members for watching, being an active part of our episode tonight. And of course, Dr. Major for sharing so much with us, for sharing his time. He is such a busy surgeon, but he knew that it was important to be here and to relay this information to us. As a reminder, this episode is proudly sponsored by Amber L. If you're just tuning in, you can watch the full replay on YouTube and Facebook. I thank you all for being here and invite you to join us next week for another episode of Vibration, where we raise your frequency and amplify your truth. Bye, everyone.